Excellent. I have no financial disclosures, no conflicts of interest. I should disclose I like to consider myself a maximally invasive surgeon, in particular when I get asked to meet with the robot reps. I do receive funding for PCORI, ARC, the Donahue Foundation, and NIH, and I'll say that most of my research is actually in patient-reported outcomes and in decision-making. And so, I'll say in researching this and thinking about this, there is a lot of phenomenal technical information. Much of it is on the SAGE's website. And so I really wanted to stay with what I know, and we'll cover some of this, but I really want to focus this talk in that space and around patient decision-making. But we'll start a little bit with the first part of that and really dig back, probably some of you further back in your medical education, talk a little bit about the physiology and the changes of the physiology. So these patients that come into our emergency department that are pregnant, this happens like just rare enough that we don't get funding for it very often to study. It's a very difficult to study population, which is why there's not much research in this space. But it actually happens often enough that we get terrified about it when we're on call. It happens about 1 in every 635 patients or so, that pregnant people come in with non-obstetric emergencies that cause us to have to operate on them. And this is common enough that it happens that we have to remember what the physiology, that happens. And these patients have increased blood volume. They're hypercoagulable, and it causes compression on the IVC. In particular, as the uterus expands, we have to make changes in positioning when we're positioning them in the beds, and it changes how we, gain access into the uterus when we place our ports, of course. I want to put this guide up here for those of you that want to use the QR code to access the SAGE's guidelines, because they're really phenomenal. And I'll put that up again through the end of the case. But let's start with the first case here. So you have a 29-year-old that presents to the emergency department who's 3 weeks pregnant. This is G6P0. This is a desired pregnancy following IVF. She has right lower quadrant pain. The white blood cell count is 16, and an ultrasound shows slight fat stranding, though the appendix is not visualized. The MRI wait is estimated to be 8 hours. Of course, you find this out about 2 hours after saying, so what did that MRI show? She then refuses the CT due to the risk to the baby. When you look back over this, it's important to remember your ultrasound that you have at your facility, it's really maybe resource limited at your facility. A lot of times after 8 p.m., it's difficult to get an ultrasound. It also is sonographer dependent. Maybe that at your facility who's on might depend on how good the ultrasound results might be. MRI, really beware the time trap. And a CT, oftentimes this informed conversations really are critical. And if it's your overnight resident, or if it's a new PA that's going to talk to patients, they might not have the information to have an informed conversation with them. So there's a lot of great resources. This is an algorithm that we use at our facility to have conversations with patients about the guidelines for radiation risk. Starting really, we're able to start with ultrasound. And then if the ultrasound is positive for appendicitis, we move forward with surgical management. It's important to note there is no randomized trials for patients for appendicitis in giving antibiotics to treat appendicitis. If the ultrasound is equivocal or if it's negative for appendicitis and an MR is available, it's perfectly reasonable to move forward with an MRI. If an MR is not available, it's reasonable to move forward with a CT scan. Single-dose CT scan is very safe. And if the CT scan is negative, of course, moving forward with expected management. If it's positive, moving forward again then with CT. And the citation is here, which gives a great overview, including the doses for radiation. In this case here, it took an attending going to the bedside. It took bringing in her primary care provider, which she had a long relationship with her prior miscarriages, to have a discussion, which then led her to move forward with the CT, which was definitive for ruling out appendicitis. Next is access. I thought, gosh, for this talk, the one thing I didn't see on the SAGE's website is great information that would say, hey, at what week do we stop really, or does it drive where port placement is? Because as many of you probably know, it's perfectly safe to use a Veris, it's perfectly safe to use optical trocar, it's fine to use a Hassan. Either of those are very reasonable, but there's probably a good research project in there, and somebody did it, like most of the research projects I think up, about 50 years ago. So there's no great data on fundal height or when that will predict it. The key for access is it's not good to learn new tricks in crisis. So as somebody who does predominantly emergency general surgery, I do the same thing every time, so that when it's 2 a.m. and it's really hard, or it's a case with somebody that's pregnant, and they're very, very pregnant, and maybe they had multiple operations, or maybe they have old stuck mesh, I'm doing something that I do even on really easy cases. So for me, I do a Hassan. I usually do it in the upper quadrants, and I just do it every time because that's my preferred way to do it. If you do a varus every way, it's very reasonable, and the guidelines support that. This is my personal trick. If it's a desired pregnancy, I also take a picture for the baby book. People like it. For positioning, it wouldn't be a talk for this without saying to rotate it. Baby laying on the vena cava, patients or anesthesia doesn't tend to like it. I'm also quite amazed at how many people tip the patient quite wide to the side at like 3 weeks gestation. Also not necessary. Moving on to case number 2. 24-year-old college student presents with nausea, 24 hours of right upper quadrant pain, and an ultrasound consistent with cholelithiasis and biliary colic. They're 12 weeks pregnant. This is the 4th ED visits in 3 weeks. And they remark that it's getting increasingly difficult to make it to classes. This is a biliary colic case. It's important to look at the ACOG guidelines. The pregnant women should never be denied medically necessary surgery or have surgery delayed regardless of trimester, because this can adversely affect the pregnant woman and her fetus. This is important for trauma cases as well. And elective surgery should be postponed until after delivery. This person has been in the emergency department for 12 hours. It's their 4th visit, and they're preparing for discharge. Their symptoms are increasingly impacting their quality of life, their ability to attend school, work, and see the people they love. They now need pain medication to manage their pain. This is not a desired pregnancy, and no one has discussed this pregnancy. I think it's important in these cases, as we talk about decision-making, to remember that women have agency. And when we are taking care of pregnant people, that we talk to them as patients, and that we remember to ask very important questions that we ask in all decision-making with the patients that we take care of. So I bring this to you for all people that we address. I'd ask them how they feel about their pregnancy. Who are the people that help support you in making healthcare decisions? When taking care of people that are pregnant, remember, this is, for some people, the most dangerous time of their lives. It's a time that's very high for domestic violence. And so if you can question them alone, it's a time to question them alone. Ask them, because this is a time when people make decisions, if it is a very desired pregnancy. Thinking back to that case that's G6P0, people actually don't make decisions with data. So ask them, what have you heard so far about X? And what symptoms bother you most so far? And what worries you most? Because you cannot get to asking patients or giving treatment recommendations until you understand this about the person first. Because this is such an incredibly charged time, there's risk distortion. And until you can really build that trust and rapport with people, you can't help them to make shared decision. What was really interesting is when we ran the CODA trial, which was the randomized trial for appendicitis, where we were randomizing people to surgery or antibiotics, we had probably 6 sites that didn't want us to include people of women that were of childbearing age. Like, they didn't even want us to include them in the trial. So we wouldn't have understood even the experience of any women, which was remarkable. And the link that I'm putting up here is the history of the FDA in 1977, when they actually excluded women at all until there was proof that any drugs that were given wouldn't have caused harm effects to fetus. And that came from a good, history where fetuses were harmed, right, when certain drugs were thalidomide. This is why I was never an oncologist. I can't pronounce any of the medications. Were given to them. And it comes from that history, but even now our IRBs, we're trying to eliminate women from the CODA study. And so as a compromise from this, part of what we had to do in the IRB and consent for a very good reason was to say, if in the next 3 months you are planning to get pregnant, we want to warn you that we don't know what will happen if you get appendicitis again. And we under-recruited women in the clinical trial. And I think that's important. It's important to give that information. It's important for informed consent, but it did lead us to under-enrolling as well. And so I bring this because that part of it, and that part of that informed discussion is really critical, but not unless you're willing to have that entire discussion with patients about their experience. Dr. Hantuli is part of our research team and faculty here who's doing a lot of really phenomenal work in trying to understand prediction models for patients, because we won't enroll them in clinical trials and we won't understand their experience because we won't be able to run clinical trials this way. And so we're doing a lot of propensity modeling, and she's leading that work, and we're hoping to have some more information. The takeaway from this is pregnant people should be able to make decisions for their healthcare for EGS conditions, symptom management, and pregnancy considerations. We need to be able to assess the symptom burden, their treatment preferences, and risk considerations. There should be a multidisciplinary discussion, just like you would for cancer care, but include their primary care providers or their OBs. And there's great resources, and I'll link again the SAGES guidelines for that. Thank you all.